This is an approach to edema. Fluid where fluid shouldn't be. You probably don't remember that equation with lots of brackets and hamburgers and minus involved hydrostatic and oncotic pressures of this and that. It's a good reason why you don't remember it, because there was a lot in that equation you didn't need. This is my take, and this is the advanced organizer, J equals snowman. Let's start off with the pieces of that equation you actually need. J, flow of fluid across, equals K times the hydrostatic pressure minus the oncotic pressure of the blood. Now, there's only one time where that's not true, and that time the next step is already prescribed for you. What actually matters is the vascular permeability and the hydrostatic pressure of the capillaries and the oncotic pressure of the capillaries. Let's walk through this. Oncotic pressure comes down to albumin, and a low oncotic pressure will cause edema to leak out. Low oncotic pressure means low albumin, and that is the oci. That is cirrhosis, nephrosis, and gastrosis. Cirrhosis, inability to synthesize albumin. Nephrosis, protein spilling out in the urine. Gastrosis, protein losing enteropathy. Usually not that. It's usually simply malnutrition. If you have a low albumin, means you have a low albumin circulating everywhere. So if you have edema, fluid where fluid shouldn't be, and it's from the oci, you should expect to see is fluid everywhere. Now we're on Earth, there is gravity, so fluid tends to pool down. But you should see a puffy face, as well as puffy toes if the person is laying flat. Oci has to do with albumin, oncotic pressure, global. K is vascular permeability. And you can feel this by just banging your knee against a wall. You do that, it's going to get red, hot, swollen, and tender. Inflammation from the trauma. And indeed, one of the things that can cause increased vascular permeability is trauma. But that trauma isn't the thing that led to vascular permeability, it's actually the inflammation. Inflammation that's local will cause local swelling. And that's usually not that hard to spot. Trauma, infection, cancer, and autoimmune disease. But vascular permeability really actually comes in a different way. Chances are if it's one of these things, and it is local swelling, like just the elbow or over the cellulitis, you're probably not going to be approaching that problem from the perspective of what's causing the edema. You're probably going to make the diagnosis of cellulitis and say, oh, hey, that cellulitis happens to be edematous. Instead, inflammation comes into play, vascular permeability, when it comes to sepsis and pancreatitis. Because sepsis and pancreatitis cause systemic inflammation. Vascular permeability, how tight the blood vessels are closed. Blood-brain barrier, not a lot gets through. Liver, sinusoids, lots gets through. If you have systemic inflammation, inflammation everywhere, and the entire blood volume goes to the lungs, and those capillaries are open, a lot of fluids are going to end up in your lungs. And that is how you develop ARDS. Finally is the hydrostatic. And that has to do with the column of fluid that has accumulated. An artery brings fluid in, veins and lymphatics take it out. You lose one of those, there is some functional reserve of both, but eventually, since the same amount of fluid's coming in, without both lymphatics and veins intact, you're going to end up accumulating fluid there. Hydrostatic comes down to the C's. There are 5 C's and a 6th confusing one. The 5 C's are clots, as in DVTs, cuts, removal of veins or lymphatics, cancer, and cancer causes compression, CHF, and cirrhosis. And that is the problem with cirrhosis. Cirrhosis that has increased portal hypertension will lead to accumulation of ascites, and also cirrhosis leads to decreased albumin synthesis, leading to oncotic pressure causes. If you have any of these things that prevent fluid from leaving an extremity, the column of water on top of that extremity is going to push the fluid, increase hydrostatic pressure, and keep the fluid in the extremity. Using that as an idea, what you want to do is find out where the obstruction is. Obstruction. There's going to be a blockage of flow somewhere in these diseases. And it's your job to find out where it is. Then, knowing where it is, look for what it is. That is the snowman part. Here's the snowman. This is a normal arm. This is a big puffy arm. Big belly for ascites, normal leg, puffy leg. Puffy because there is edema. What you do is you start at the heart and work your way back. If it's the left heart that's obstructed, you're going to see pulmonary crackles. If it's the right heart that's obstructed, you're going to see JVD, congestive hepatopathy, and peripheral edema. If it's the liver that's the problem, you'll see some ascites. If you have clots or cancer or compression of a vein or lymphatic of an extremity, only that extremity is going to be affected. So using where normal turns to puffy will determine the location of the obstruction. And generally, if you have something of the upper extremities that's puffy and the rest of it isn't, is something in that arm that's causing the problem. The only trick here is that CHF, you have to look at the central causes because CHF can lead to ascites. CHF can lead to peripheral edema. Only CHF leads to JVD, where a DVT would not. So this is an approach to fluid where fluid shouldn't be, edema. It comes down to inflammation, generally local, oncotic pressures, global, don't be tricked by dependent edema though, and a regional hydrostatic pressure where you localize where normal changes to puffy and look there, generally with an ultrasound or a CT. That is the approach to edema.